I'm Sanda Moldovan. I'm a periodontist.
I'm Olga Malkin. I'm a prosthodontist.
We wanted to talk to you about today about all-on-4 treatment concept and really our method we use to make sure that the treatment is successful. So most of our patients that are actually coming into our office are actually dentate patients. We know that more than 80% of people seeking this kind of treatment are with teeth. So how do we ensure that they get exactly the smile that they want? We're going to divide our presentation into the pre-treatment, what are the necessary steps that Dr. Olga needs to take to ensure that the prosthesis and the smile is exactly as we envision it. Then we're going to go through the treatment and a surgical video on this top and bottom all-on-4 prosthesis. And then post-treatment, what do we do to ensure that the healing goes smoothly with a minimal amount of pain and trauma? So if you see here, these are some of our patients. Some of them come in with just a few upper teeth remaining, and some of them are fully dentate with a full arch dentition. And really it's a failing dentition which needs to be transitioned into a full arch prosthesis. So when we're looking at the pre-treatment, it is really important that we align our expectations to our patient. So there's really three things we have to align our expectations about. One is a smile, one is money, and one is downtime. So the smile really has to do with the prosthetic preparation. Money, of course, our treatment plan coordinator has to discuss this ahead of time. There shouldn't be any surprises, and we'd like to give you some tips on how to avoid any surprises. And also downtime, I will give you some nutritional tips and homeopathic tips on how to ensure that the patients heal with the least amount of pain.
The important thing that we have to tell the patients that all-on-4 is actually an alternative to a denture. It's not an alternative to a natural dentition. So you have to create that type of expectation for the patient that it's not going to feel like natural teeth. At the end of the treatment, they might feel that this restoration is actually better than their natural teeth because they don't have any pain, there is no moving teeth, and they're able to function and smile naturally. But that's something they have to be reinforced, that it's an alternative to a denture. Now, let's look at how we create this beautiful smile for our patients. When they wake up, the first thing they're going to see is their smile and how well it fits their face. They don't know how well the implants are placed. All they can see is their smile. So we want to go over three things that are very important in creating this beautiful smile for our patients. First of all, it's anterior tooth size, shape, and selection. Secondary, the pink and white balance. How much of a tooth structure, white tooth structure they're going to show, and how much of pink gingiva they're going to show. An important third step is creating an appropriate buccal corridor space for the patients. So let's look at the anterior tooth selection. And what's interesting about all-on-4 treatment planning, we actually have to go back to the denture fabrication rules. And what I like to do with the patients, because they have anterior teeth, they're usually dentate patients, I like to use F and V sounds for the patients to determine the position and the length of the anterior front teeth. So when the patient says F and V sounds, the teeth and the incisor edges of the anterior teeth should hit the dry, wet line. So you can actually record this on an iPhone or take a picture of that to send it to the dental laboratory so you can communicate with your technician. So we can see on the slide on the first picture, in the first profile, that's an ideal tooth position for the anterior teeth. You can see that they're hitting the wet, dry line. In the second profile, you can see the teeth are set too far in. And on the third profile, you can see that the teeth are set too far forward. So evaluating the patient's existing dentition, you can actually tell your dental laboratory that I want to keep the teeth in the position where they are now, move them out a millimeter, move them in a millimeter. Another second thing that you can cross-check that you actually determined that position correctly, once the teeth are set on the model, you can take a measurement between the base of incisal papillae and the incisal edges of anterior teeth, and that length has to be around 12 millimeters. This is kind of the second thing you can check yourself to make sure that your in person with the patient evaluation was correct. What sometimes I see that in a lot of this denture conversion intraorally, the patients end up with its teeth a little bit far forward. Why does that happen? It happens because the denture was not seated properly in the mouth. It was either held back from seating by a soft tissue or the bone. Another reason, because the flange, the anterior flange, labial flange of the denture is too long, and it prevents the seat of the denture. So then the teeth end up a little bit too far forward. And that's very noticeable for the patient. So a good trick, especially if that's something you're starting to do for the first time or in the beginning, to give yourself a little bit of leeway and set the teeth a little bit slightly more in from where you think the ideal position might be.
And actually what I see, Olga, with other practitioners I work with is that a lot of times the prosthesis ends up too forward instead of too back. And a lot of patients are unhappy with that protrusive look.
That's exactly right, because patients notice when the teeth are a little far forward. They don't really notice when they're a little bit more in, especially because you're definitely giving them a restoration that has much wider teeth that probably they started out with. Now they have a full set of teeth. So just the first impression of that is always that all of a sudden you have bigger teeth and they kind of the more toothy type of a smile. So keeping yourself a little bit on the inside, keeping the teeth a little bit in, is a good rule of thumb to kind of give yourself some room for error. The second thing we have to look at the anterior tooth selection is the shape. Shape is very important. So what you can be guided on with to just kind of help you with that is the shape of the face. So for example, if you have a patient with a square face, you can select square teeth. Now, if it's a female, you can select square ovoid teeth to make it look more feminine. If they have an ovoid face, long teeth, you can select longer ovoid teeth. And the third usually shape of the face that you see is the tapered face. And you can select triangular tapered teeth for that type of a patient. And again, you can make them somewhat tapered ovoid if it's a female patient. And now we're going to get to the size of the teeth. And my advice is to get to know the denture tooth line that your lab is utilizing, because most of the lines today are coming with the measurement aids to help you with the selection of the size of the teeth. So I use Heraeus-Kulzer teeth. They have a facial meter that measures the width of the nose and correlates it to the size of the teeth to put you within the ballpark. So you can actually ask patients to provide you with pictures of their smiles before they started having issues with their teeth. You can look at their family members. Sometimes you can see that the child, they come in with a escort, the adult child who has a very similar skeletal anatomy, or brother or sister, usually, the same sex, obviously.
No, if you have that patient who actually brings you in a photo of Cindy Crawford and they want to look just like that, that's a patient you have to refer to your friend.
We're not magicians. We're doctors. We can create a little bit of magic, but we cannot transform patient into somebody else. So now we will be talking about pink-white balance. And the good guideline is to use the shape of the teeth that lets you show the least amount of acrylic. Because when you show pink acrylic, that's what makes the restoration look like a denture. So you can see in the first picture here, this is the mistake that I actually made. You can see, just like we talked about, the teeth are a little bit too far forward because this patient had a lot of extraction. It was hard to reorient the denture to put the teeth in the proper position. Also, what happened with her is that her teeth are a little bit too short. So actually, we redid the restoration for the patient, which is important to redo it in the temporary stage. You don't want to wait until the final restoration because you want the patient to function in this tooth position before you go into the final restoration. So you can see we chose longer teeth. And in the type of teeth that I use, you can see the bottom teeth are a little bit shorter. The top teeth are longer, even though it's a very similar size of a tooth in terms of width. So that's a good technique to use. Sometimes you can have an opposite situation. For example, you have a patient here, And he's wearing snap-on smile, so you can see the teeth are a little bit too bulky, especially on the canines. But when he smiles, you can see the anterior incisors are a bit too short to follow the smile of the lower lip. So if we just lengthen those teeth, they're going to look like long, narrow teeth, not very attractive. However, if we add some pink acrylic and show a little bit of pink acrylic, we can use a more appropriate size of the teeth. And when you show just incisal papillae, that actually looks natural and blends in and doesn't make it look like a denture. So it's a very good technique to use. And the third thing we're going to talk about is about the buccal corridor. So what is a buccal corridor? It is a dark space between the corner of the mouth and the buccal surface of maxillary teeth. So let's look in the middle. You can see in this picture that the teeth in the back are set in a little too far in, so the buccal corridor is not filled in properly, so it doesn't make for an attractive smile. On the lower picture, you can see a very nicely developed buccal corridor, and you see a very nice smile. So you want to have a more of a U-shaped arch. So let's look at our patient on the bottom. You can see that she's missing some back teeth, but you actually see a lot of dark space posteriorly. So we really need to develop her buccal corridor, give her a nice, attractive, wide smile, and that's exactly what we did here. And that's creates a very nice look for a patient. So let's talk about our restoration. And we're going to talk about our restoration in terms of three measurements: height, width, and length. So let's talk about the height of the restoration. The height of the restoration is determined mostly by three factors: smile line and transition line, restorative space, and the type of a defect, if it's a composite defect or a tooth defect. So let's look at our smile line, transition line determinant of the height of the restoration. So you can see in the middle, we have a schematic here. The red line is the smile line, and the green line is the transition line. Transition line is the transition between the restoration and the patient's gingiva. And this transition line has to be always above the smile line. It has to be hidden by the upper lip. And it's very important not to make that mistake, and it starts during the evaluation of the patient to determine where that is.
So this part is really important, especially for those of you who are doing the surgery and you have a restorative doctor who's not giving you that information of how much bone to reduce. It becomes a real issue, because once we have placed the implants, we cannot go back and give you more bone reduction. So having a good communication between the surgical and the restorative team is key for us to be able to hide this transition line.
Because if that mistake is made during the surgery and the transition line is not hidden, now you have to go to an overdenture. And this patient came in to you to have a fixed restoration. So it's a failure of the treatment right there, even if the implants are integrated. So that's very important. So let's look at the patient here. We can see that this patient, when he smiles, he doesn't show any gingiva. So the transition line is hidden. So we don't have to do bone reduction in most of the cases like that. However, when we look on the other side of the slide, we can see a patient that has a pretty high smile line. So you can see the smile line is in red, and we can see gingiva. So we know we'll have to do some bone reduction. And that's a more challenging case.
Yes, Olga, I agree with you, especially if you look on the right side of the screen. We have the green line here, which represents the transition line of the prosthesis, and then above that, we really have a black line there representing the bone level. And ideally, we would like the bone level to the transition line the soft tissue thickness, that is, to be between 2 and 3 millimeters. And a lot of times on the palatal side of the posterior maxilla, we see up to 5 millimeters in tissue thickness. So as a surgeon, I always go in and thin that area out so we don't have a big discrepancy between the buccal flap thickness, which could be sometimes 2 millimeters, and the lingual flap thickness could be 5 millimeters. We want to bring them both to the same platform so you can choose the right multi-unit abutment level in that case.
So how much space do we want to have between the smile line and the transition line? And we want to have minimum 3 millimeters. And we're basing that on the lip position at the forced smile. And that's why you have a little bit of leeway, because usually patients don't smile that way naturally. So 3 millimeters is minimum. And just like Dr. Moldovan said, that we want 2 millimeters of tissue thickness. So you want the bone to be minimum 5 millimeters away from the smile line. And that's a minimum. If we can have more, that would be great, but we're limited by certain factors such as
the pneumatized sinus, for example, on the posterior maxilla. Also, on the lower, we have the mental foramen. But usually the lower is not a problem. It's mostly the upper when we talk about the transition line. Rarely we see the transition line being a problem on the lower teeth.
And that's something is very important to determine ahead of time, because some patients with a very hyperactive lip might not be a good candidate for an all-on-4, and that's something you have to determine during the treatment planning phase, and I'll offer your patient a different option. So how much restorative space do we need for appropriate height of the restoration? So you have titanium framework with denture teeth, we want at least 11 to 15 millimeters. So that's enough space for the framework, pink acrylic, and denture teeth, so we don't see fractures of acrylic or denture teeth. If you do not have enough space, you have to think about other restorative choices for the materials. For example, zirconia framework, when you need to have with porcelain layered over it, when you need to have less restorative space. And another thing to really pay attention to is that you might think that you don't have enough restorative space, but you might be at a collapsed vertical dimension of occlusion. So you have to make sure to evaluate it properly, and if it needs to be increased, then you have to reestablish the appropriate vertical dimension of occlusion. So, and the third determinant for the height of your restoration is what type of defect the patient has. For most of, I think, all-on-4 cases, I think we see more of a composite defect.
Definitely. We see more of a composite defect like you see in these two animations. Rarely we see a true tooth defect. And in that case, then you're just looking at mainly a zirconia restoration, not an acrylic-based restoration. But I would say more than 90% of our patients are into the composite defect.
Absolutely. So if we look at this patient, again, that we saw in the beginning of this portion, we can see that she doesn't have a lot of bone loss, and it looks like if we extract the teeth and don't reduce bone, she's going to not have enough restorative space because it looks like just a tooth defect. However, if we look at this patient very closely, what we can see that her vertical is actually really collapsed, and her lip support is also insufficient. So if we reestablish proper vertical dimension and give the patient a proper lip support, all of a sudden we can see that she actually has a compound defect where she needs to have both pink and tooth color on her restoration. So that sometimes could be hidden in the patient's existing dentition and vertical, but very important to catch something like that. So it's a composite defect for this patient.
So here actually when we look at the width of the restoration, that becomes very important, especially for the oral hygiene, as well as the strength. So ideally we'd like to align the implants over the top of the ridge, like you see in these photos. All the way on the left-hand side of the screen, you can see how the implants here on this mandibular prosthesis are way too lingual. So the buccolingual dimension of this prosthesis is not at all what we're looking for. This patient will have a very difficult time cleaning. It's a prosthesis that you probably have to remove every 6 months, and that creates a whole other set of problems, like a screw breaking when we remove this prosthesis, and the time that the patient has to spend in the office. We want the buccolingual dimension for the especially the prototype smiles to be thick enough to be strong, but not too thick where we cannot clean them. On the right side of the screen, we see here that concavity on the intaglio surface is a no-no. We definitely need to have these corrected before they are inserted into the patient's mouth. So send it back to your lab to have something like here, where you see there's a flat intaglio surface, so the patient is able to clean that with an oral irrigator on a regular basis.
Exactly, and also another thing you have to pay attention to, if this is something you have to do to hide the transition line, you cannot have that. You still have to remove all this excess acrylic, and then you might have to consider an overdenture for a patient.
So picture 1 and 4 is not what we want for our patients.
And another thing we'll look at is the length of the cantilever. So what we have in the first X-ray, we can see the properly angled implant. The sinus is quite far back, so we can put a multi-unit 30-degree abutment to correct the angulation. Sometimes what we have to do to create more support for the temporary restoration and the permanent restoration is actually angle the 30-degree abutment backwards, so it creates more spread between the implants, and it prevents the fracture of the cantilever. And whenever you have a fracture, you can see it fractures around the temporary abutment. So in this picture here, on the lower left-hand side, you can see this is the proper cantilever that you want to have, just maybe half a tooth at the most.
Let's talk about money, everybody's favorite subject, especially when we're talking about a 5-figure treatment. A lot of our patients have a sticker shock, perhaps. So I think it's important to establish the value of this treatment. This is not like a car, and a lot of patients say, wow, that's the price of a car. Well, when you think about a car, it's really good for 5 to 8 years. 10 years maybe if you have a Toyota, but then you have to buy a new car. Not so with this. Once you have it, it's pretty much good for life, and the prosthesis may need adjustment and modification and replacement, but for the most part, implants are for life.
So what you have to also establish with the patient, especially when you have denture teeth, they're going to have some wear, so you have to have it hopefully in your consent form as well, that they understand that in a certain amount of years, the teeth might have to be replaced. Now, the titanium framework, which is the most expensive part of the restoration, can be kept. The patient can be transferred back in their provisional restoration, which is very similar to their final one, so it's not such a big change. And the new denture teeth can be applied to the already existing titanium framework.
So it's important to have the financial conversation with the patients initially, and especially with the fact that if they want to upgrade to a zirconia restoration, that's a whole nother fee. And I think this should be discussed before we even place the implant.
Definitely has to be discussed prior to treatment, and I always tell my patients that you can decide that during your temporary restoration if you want to upgrade to porcelain teeth, and that's a good time to decide because they can feel how acrylic with denture teeth feels like in the mouth.
And there's different financing companies out there. A couple of them that we work with are Lending Club and CareCredit, and they do offer extended treatment plan options as a third party for up to 5 years to make this affordable for our patients.
And obviously you have to believe in this treatment, your staff has to believe in the treatment, they have to see the successful outcomes for your patients.
Downtime. So something we need to prepare the patients for is downtime after the procedure. If we can keep the procedure to a minimum, we don't have to raise flaps. Actually, if we can do it flapless, even better with the Nobel Guide technique. Or even if we can just raise the flap up to the mucogingival junction, then we don't see swelling associated with the procedure. However, if we have to raise a flap to be able to visualize the sinus, the subnasal floor, and really place the mucogingival line apical to the original position, then we're going to get something like this where you see bruising and swelling.
And actually, the patients are not in that much pain. They just have bruising and swelling, but you have to prepare them ahead of time. Then they send you a picture like this as a joke, not as a complaint.
He's still smiling because he's
Exactly.
happy with his teeth. And actually, in that case, he was actually an alcoholic before, so I think he was still drinking. So if you have somebody drinking wine the night before surgery, you can be sure you're going to get more bruising and swelling. Here's the treatment part of the surgery. So Dr. Olga fabricated her prosthesis here. We see it on the cast. And then during the surgery, both working together on the same patient, as you see, because we are meeting at the gum line and we want to make sure that she gets enough bone reduction so she can properly install the prosthesis. So I always use the all-on-4 guide even when I place the dental implants. The reason being, I want to make sure I don't change the angle of this implant as it is being placed, because oftentimes with the Nobel Active implant, which is my choice of implant for this treatment, we can do that even after the final drill position. We have a video to share with you that Olga and I did together of a patient in her 40s. She's a mom of 4. She was busy all her life taking care of her kids, and now it was time for herself to take care of her. And her number one requests were she didn't want to be judged by anyone. So we're going to go through step by step how we did the surgery. We're not going to go through the preparatory phase. So at this point, the upper and lower dentures were already fabricated.
So we'll go through the steps of loading this implants and converting the denture to the implant supported bridge.
Enjoy.
lady.
TV lady. Yes.
So you can see our patient, you can see it's quite a bit of change even in her profile. So you can see now she has an appropriate upper lip position and she has natural teeth. So what I would write to the lab, we can see that the incisal edges of lower teeth are where the incisal edges in terms of anterior posterior position of maxillary anterior incisors should be. So I would tell the dental laboratory to position maxillary incisors in the same anterior posterior position as lower incisors, make them, let's say, millimeter longer. And then I would instruct the dental laboratory to create 1 millimeter vertical and horizontal overlap in terms of the occlusion.
But this is basically doing orthognathic surgery on a patient to be able to get these results. So with the all-on-4 treatment concepts, we can achieve significant shifting of the facial structures without all the trauma of orthognathic surgery.
Absolutely, and obviously this patient's occlusion was collapsed, so the vertical dimension of occlusion had to be increased and reestablished.
So here's the surgical guide that I used during the procedure, but if you see this slot here on the ridge, it's a good guide not just for surgery, but also when we insert our multi-unit abutments. During surgery, I actually stop periodically, especially after multi-unit abutments were inserted, just to make sure that the multi-unit abutments fits perfectly into this occlusal space to allow Dr. Olga to make the restoration exactly the dimensions buccolingually that we want. If you actually place the implant too far palatal, then you end up with a thicker restoration, which is very difficult to clean.
And it also interferes with the patient's diction, which becomes very distracting to the patients, and they're not very happy about that.
Here's the guide in the mouth, and you can see after I extract the teeth, I place it to see where the restorative platform should be. And oftentimes this ends up to the palatal of the extraction sockets, not to the buccal. So it's important for you to check, even though we're using this all-on-4 guide, to also use a clear duplicate of the denture to ensure that the implant platform and the multi-unit abutment direction is in this restorative space. And here we have, after the implants have been placed, you could see here the palatal position of the implants all the way across. And here you could see some of the threads being exposed due to the trauma from the infections of this patient. Typically, these areas we can graft if we have autogenous bone, which we removed from the ridge, or you can let them the blood clot fill in the spaces. And we suture using a resorbable suture after the multi-unit abutments were placed.
And it's important to have a different selection of multi-unit abutments because you don't know what variations you can have at surgery. So if you look at the slide here with the multi-unit abutments, you can see then one of the multi-unit anterior abutments is angulated abutment, 17 degree, and the other one is a straight abutment. So it's important to have selection of both angulation and height.
And oftentimes I try to place the implant as axial as possible, but because of the concavity that exists on the anterior part of the maxilla, then I need to angle that implant so we end up with a 17-degree abutment.
So we have three types of multi-unit abutments. We have a straight abutment that can be torqued to 35 Newton centimeters. Very important to know your torque values. And we have 17 and 30 degree multi-unit abutments that can only be torqued to 15 Newton centimeters. So you can see how we position the posterior multi-unit abutment, which has a bit of a learning curve. You can see there is a carrier that helps you get the idea of where your screw channel on the temporary or permanent restoration is going to be, and have to be as perpendicular to the occlusal plane as possible. If it's tilted a little bit posteriorly, that's not a problem. if there's a little bit of divergence between the anterior and posterior implant, we can still see restoration passively because the temporary copings and the bridges titanium framework that goes over those abutments is non-engaging. So we can have some leeway in terms of the angulation. Now, the multi-unit straight abutment has a special driver for it that fits over the top of the abutment, and the angulated abutments are placed with the regular uni-grip driver. A very good device for placement and torquing down the multi-unit abutments is a handpiece driver like this. It can be purchased, I think, from Salvian. Mm-hmm. So it's a very helpful, especially if you're restoring one arch and you don't have a lot of space to place a regular driver. Also, a lot of the abutment screws on 30-degree abutments are either pointed posteriorly or towards the cheek, so it's not an easy access. Now I'm indexing the position of multi-unit abutments with a quick set bite registration material. You can see and make sure that you can clearly see where your abutments are. And we can see this just drilling out the areas where the abutments are, so we can pick up the temporary cylinders. Now we see this temporary cylinders in place. Most of the times I have to cut temporary cylinders. The reason is I want my patient to close into occlusion so I can make sure that positioning of the denture that I'm converting is correct and the teeth end up in the proper position. And you can see the openings, some of them are a little bit on the wider side, but that's fine. You have to make sure that there's enough space circumferentially around the temporary coping so it doesn't, the denture is not being, the position is not being thrown off because there's a temporary cylinder holding up a denture somewhere.
And the least parallel these four temporary cylinders are, and oftentimes I have to angle the posterior most implant to 45 degrees, then the bigger the holes need to be.
And what we do, we actually started using Teflon tape, which is a really nice device, a really nice thing to use as opposed to actually rubber dam. We soak it in Paradex and we place it, making the holes with a rubber dam punch. And it helps in a few things. First of all, first of all, it helps with not ripping out the sutures, which can cause additional bleeding and doesn't make your surgeon happy at all. And also what it does, it helps with the control of bleeding around the temporary coping so you can easily pick them up and make sure that acrylic gets attached to them. So in the middle picture, you can see that I actually like to use jet acrylic because it offers me options with the same monomer of both pink powder acrylic and the tooth-colored powder acrylic, because sometimes in the back you can see that the openings are made through the teeth, so you don't want to pick them up with pink acrylic. It's not going to look nice. So, and whatever the acrylic that I put inside the denture, it doesn't have to be runny. It's kind of a little bit on the thicker side so it doesn't go all over. And there's still plenty of time to sit it in place, clear up the temporary cylinders, and make sure you can see that I'm making the patient, because the patient is IV sedated, close into occlusion. Then I would remove the retractor and also check the lip position. So what you can also do, if you look at this denture very carefully, the labial flange is shortened to the transition line. So that makes it important, because this way you can see that the labial flange is not interfering with the seat of the denture in the proper position, and this way you can have the teeth where they're supposed to be. So we have to wait. The worst thing in dentistry we have to do is to wait, and we have to wait until the acrylic is no longer warm, and you have to make sure that you wait maybe a little bit longer because you want to make sure that all the temporary cylinders are engaged. Once you remove it, you can easily peel out the Teflon tape.
And try out to make sure that gently with a periodontal probe to see if these are rocking. If you see any of them moving, then we have to insert the prosthesis back and use more acrylic to secure it.
And if it's wiggling just a little bit, you can kind of see where it's supposed to be. So you can index it in that place with a flowable composite so it doesn't move around, and then you add acrylic over it. You cannot just leave it in composite because it's not strong enough. So you can now see the temporary restoration, and it has a very good anterior posterior implant position. It's right in the middle. You can see on the front view that it's very easily accessible for hygiene for the patient, and that's what we want to see. And it makes for a happy patient. Now, this is kind of an easier case to start out with. The transition line is hidden. It's both tooth and bone defect, doesn't need any bone reduction. You can actually train the teeth ahead of time just to make sure that you're where you should be. So it's a good case to start out with.
Definitely it's better to start out with a case that doesn't require any bone reduction initially.
And has a hidden transition line. And those are our patients. Both of those pictures are taken within the first 2 weeks of the healing, and you can see that there's a nice healing around these restorations because they are attached to the implants, so the tissue is able to heal easily, as opposed to when you have a removable dentures. Any restorative doctor you know that it's not fun to be adjusting those dentures. So this is much better for our patients.
So 3 things we would like to talk about is occlusion check, soft tissue healing, and pain management for these patients.
So in terms of the occlusion, you want to have even contact distribution. It's very important. You might have to adjust it on several occasions, especially when you're changing somebody's occlusion significantly as they're settling into their occlusion. You cannot have any contact on the cantilever, and you can see where the markings are for ideal contacts. The contacts in the back have to be tight, and the contacts in the anterior has to be light. And what I like to utilize a very thin articulating paper. I cut it in half so I can actually check how tight the contacts are. So in the posterior that has to be engaged, almost ripping the paper when you try to pass it through, and in the anterior it just has to slide down with possible little catch. So the adjusting occlusion is really important, and you have to get your patient back in a week after surgery because now they're not sedated, and you can definitely evaluate the occlusion, make sure it's very well distributed.
A little bit about soft tissue healing. As you know, I'm also a nutritionist, and I always check for the patient's wellness state, not just the illness. A lot of them may say that they have perfect health. You look at the medical history, they have no diseases, but then they have this grayishness to their skin, yellow in the white of the eyes, and somebody like that can't possibly be well. They probably have some underlying chronic issue, either nutritional deficiency or generalized inflammation. And it's an epidemic really all over the world where we see generalized chronic inflammation on the rise. So we optimize the surgical results with personalized nutrition via blood testing, and we do have a whole nother lecture on that in the guide library. So if you look at the wound healing, we really have 4 stages, and these stages really overlap. Initially, in the first 24 hours, the platelets take over, and we have the fibrin clot, which acts like a glue to basically start this area to close. Then the inflammatory process is about 4 to 5 days into the healing. The blood vessels dilate, and the cells go in to clean the debris, and new blood vessels start to form and grow. Now, if this inflammatory stage goes more than 4 or 5 days, then patients have chronic inflammation and pain. And if somebody is not well, we will see this inflammatory stage really lasting well into 2 weeks after the procedure. Tissue building happens all the way up to 90 days following surgery, and we have new epithelium, bone, connective tissue starting to form, and the growth factors are so important during this phase to make sure that all these processes happen at a regular pace. Then we have matrix maturation, and really the bone can take up to 2 years to fully mineralize. And if somebody has an acidic diet, what we see is that the body is using those minerals to normalize the pH balance, and we see bone that really doesn't mineralize, and that's when we see implant failures. So ensuring that somebody has an adequate nutrition, adequate amount of minerals, and it's not just calcium that we need for healing, it becomes very important to do nutritional counseling. Some retarded retarding factors when we talk about wound healing. So in the first 24 hours, if somebody's on blood thinning medications or supplements, something like vitamin E, aspirin, or even fish oil. A lot of people take fish oil today and they even forget to put it on their medical history. And make sure you ask, because for actually heart and brain health, some of the doctors actually recommend 2 to 5 grams of fish oil, which can actually cause bleeding even up to 3 days post-surgery, and it's just very uncomfortable. During the inflammatory control, if somebody has a long-term use of NSAIDs, fatty acids such as omega-6, and sugar, that creates a lot of inflammation, a prolonged stage 2, which can be an issue with discomfort. Stage 3, when we're talking about tissue building and connective tissue formation, we really need oxygen. That's why smoking impacts healing, because smoking decreases the amount of oxygen in the tissues. A deficiency of vitamin C is on the rise today because most people are switching to go towards processed foods, especially some of these patients with such a broken down dentition. All they can eat is processed food, mashed potatoes and Jell-O. There's really not much nutritional value in those kind of foods. So encouraging them to have smoothies to increase the level of vitamin C, or actually take vitamin C supplementation, becomes very important.
And I think it's a good time for them to actually look at all the supplements, because they're going to be changing their diet, because we have to put them on some type of a softer diet after the restoration. So actually it's a good time for them to take a look at their diet and their supplements.
Definitely, and especially to write them down adequately. A lot of our medical histories don't even include what kind of supplements are we taking. So definitely take a look at your medical history and make sure you ask your patients what supplements are they taking. 2 out of 3 Americans are taking supplements today. An insufficient amount of protein and minerals can also cause failure, especially when it comes to bone mineralization. So B12 is also a very important factor in bone mineralization. Vitamin D, calcium, magnesium, zinc, and a lot of our diets are deficient in minerals, and a mineral supplementation for this stage is important, even up to 2 years following the procedure. This is one kit that we use for recovery support from Vitamedica. It's actually meant for surgery. So a patient would start this product 2 weeks prior to the surgery and continue 2 weeks after. And it comes with the AM and PM vitamins necessary for healing, as well as enzyme therapy and arnica, as well as also probiotics to aid and accelerate healing. Microcurrent and PMF treatments. This is an area of energetic medicine that's really been exponentially increasing, especially in research, and it aids in the recovery, speeding up healing, decreasing pain and inflammation. Homeopathic remedies can be very helpful, especially for those patients that perhaps are recovering addicts and they cannot take narcotics. So something like Arnica montana or belladonna can really be helpful in bleeding trauma and subsequently like cellulitis or fever. Hypericum we use for nerve pain or regeneration. Nux vomica is for nausea. Sometimes when taking the antibiotics following the procedure, nausea can set in. Nux vomica is very safe, as are all homeopathic remedies. If somebody develops aphthous ulcers post-injection, especially from the local anesthetic, borax is a great homeopathic to help heal that part. Last but not least, we do want to talk about implant maintenance. It is so important to have this discussed during the informed consent, because we have to get these patients to commit to coming in every 3 to 4 months, especially in the first 1 or 2 year following the prosthesis insertion, so we can keep track of the implant healing.
And you have to maybe also include it in your consent forms, that they realize that it's not one-time procedure. It's something they have to follow up, come in for regular recall. And for restorative practitioner, that's really important, from the fact of maintaining restoration, but also in terms of the business revenue, producing patients for your recall protocol.
I have a paper here that was published in 2015 in the journal of Clinical Periodontology, and it was a committee which actually looked at how can we help our patients prevent peri-implantitis. And I picked here 4 of their recommendations. Number 1, during a recall, we have to make sure that we look at bleeding on probing. So what that means is that we actually have to probe around these dental implants. Number 2, we have to make sure that the tissue is attached and keratinized. Very important. If we have thin movable tissue, oftentimes that's when we see bone loss around dental implants. Number 3, we have to make sure that our patients come in for their regular maintenance visits. They actually recommend 3, 6, 12 month, but I prefer closer to the 3 month.
And as a restorative dentist, you're going to be seeing a lot of you who don't do the surgery but do the restoration. You're going to be seeing these patients. It's really important for you to evaluate their keratinized gingiva and catch the problems before they end up in a complicated issue and refer the patient back to the surgical specialist that you work with.
And I do recommend taking a photo. A photo is best because you can take a photo at the insertion of the prosthesis, and then every year after that, just get in the habit of taking a photo with your iPhone, put it in the patient's chart, and see how the tissue is changing. The last recommendation is somebody who has had a history of aggressive periodontitis and ended up going into an all-on-4 prosthesis. Definitely have those patients on a shorter recall interval, so every 3 months, for example, and explain to them the importance of that because they've invested already so much money in these restorations. We want to make sure they maintain them.
And again, treatment planning for all-on-4 restoration is nothing new. We're going back, like in this picture, to something old. This is one of the oldest buildings in New York City, next to the newest one of the newest buildings in New York City. You're going back to the denture fabrication, which is not a new concept. It's something that all of us learned in dental school, so it should not be intimidating. It's just proper treatment planning for both surgical and restorative specialists is important. And both surgical and restorative specialists need to know both surgery and restorative to help each other and work as a team or be able to do this procedure from beginning to end on his or her own.
Thank you very much. We enjoyed being here with you today.
Thank you.